Today we are going to discuss about refractory dermatophytosis. All of us, we know that we are facing exponential rise in dermatophytosis, not only exponential rise, but either recurrence, relapse, partial response, or no response to the treatment in large number of patients with the background of HIV, that one of the most important factor is counseling, adherence, and compliance. We have done this clinical observation study and we found that our result is almost 84% of the patients showed no recurrence or no relapse followed for 1 year. Only 16% of the patient who showed partial response with the problems, so they were on either immunosuppressive drugs for a long time or the problem was adherence or compliance even with repeated counseling. So when you are dealing with the refractory dermatosis, as I said, there are multiple factors. Another factor is drug factors, that is treatment of dermatophytosis. Of course, in today's scenario that topical treatment is not enough. We have to give combination of topical plus systemic. The reason being most of the patient they comes to our clinics are with extensive lesions or there is a history of application of steroids by patient. So they need both topical and systemic drugs. But when you are talking about the systemic drugs, there are many systemic drugs like grisophulvine, terbinafine, itraconazole, and fluconazole. But what we need is the ideal drugs. But among these four drugs, last 3 years, we kept on comparing all these four drugs in our patients and their world literature. And what we found with our clinical experience and the literature, fluconazole is one of the best drug compared to all these four. The reason being, itraconazole is effective, terbinafine is effective, grisophulvine is effective, but we wanted the drug which is what we call is the ideal drug, that the definition of ideal drug, that has to be potent or effective drugs, it has to be safe drug, it has to be cost effective, or it should be affordable to the masses, because we are living in a country like India where there is a financial constraint. Of course, there are more characteristics that drug should be convenient to take, it should have minimum drug-drug interaction, it should not have resistance. So when you go for all these characteristics, what we have found, fluconazole is a better drug compared to other grisophulvine, terbinafine, itraconazole. For example, you take the potency. Even the terbinafine, itraconazole fails. Fluconazole works, and this study has been published by Dr. Kabir Saidana from Delhi. Then drug-drug interaction. Itraconazole has got a lot of limitation because it's a drug-drug interaction, while fluconazole has got minimum drug-drug interaction. Then coming to the concentration of drug in the stratum corneum is more important. So concentration of itraconazole terbinafine is 8 times in the stratum corneum compared to plasma, while fluconazole has got 40 times compared to plasma. So as per concentration concerned, fluconazole is better. Secondly, side effect wise also fluconazole. Thirdly, the patients comes with a kidney problem, we cannot use itraconazole. And if the patient come with the liver problem, we cannot use terbinafine, but fluconazole can be used by monitoring functions of kidney and liver. So when you ask me about my clinical experience for last 3 years, we are using fluconazole in each and every case, even it is very safe in lactating mother and infant. There are a lot of literature on it. So we have found fluconazole is a drug for masses, affordable, safe, and hardly any drug resistant. So we will suggest, or in fact, me and my team always we are using fluconazole, and we found there is hardly any recurrence and relapse after following almost 1 year. Thank you.